friendship, and respect. Our esteemed speaker today is Mr. Tahir Janmohan. He is the founder and CEO of Managing Life, a digital health company that is improving the lives of people with chronic pain. Prior to Managing Life, Tahir spent 8 years as a strategy and analytics consultant at IBM. Tahir is a professional engineer in computer engineering from the University of Toronto and has an MBA from the Rodman School of Management. Over to you, Tahir.
Thank you so much. Thank you for giving me the opportunity to share a little bit more about my journey in managing life and building this company. Today, I'm going to go through a presentation with you and share a little bit more about myself, and how I got to where I am today, a little bit more about the company and what we do, and then more specifically, what are 3 of the challenges that we had to encounter, or I had to encounter as I kind of built out Managing Life. And hopefully this will be a useful piece of information as you kind of go down your own career paths. And I'm happy to take questions on. You can either interrupt me, but I will leave about 15 minutes at the end of the presentation for specific questions. So feel free to type them in the chat and I'll hopefully get to them. So to get started, as Mary mentioned, my name is Tahir Janmohan. I'm the founder and CEO of Managing Life. We're a Toronto-based digital health company that's entirely focused on improving the lives of people with chronic pain. And if you're not familiar with what chronic pain is, it's very, very generic. It's pain that lasts longer than 3 months. So it's arthritis, it's back pain, it's neck pain, it's migraine. There are thousands of underlying conditions that cause chronic pain. And the way that we empower people is through our digital solution called Manage My Pain. It is now the most downloaded and top-ranked pain app globally on both Android and iOS, and the only one that's been clinically validated to improve outcomes. But before I get into the details of the company, I'll give you a little bit of background about myself. Mary had mentioned a little bit about myself. I did my computer engineering degree at the University of Toronto, spent about 1.5 years working as a software engineer out in California for an FPGA manufacturer. They make programmable computer chips. And during my time there, I remember pulling up to work one day in my car and just sitting in the parking lot. And I looked at my roommate at the time and I said, I don't want to go in anymore. I don't like this. And so I quickly realized that I needed to find a different career instead of just working as an engineer. And at that time, I applied for a joint engineering MBA program at the University of Toronto. And I was actually able to do my MBA immediately after that. And when I graduated from my MBA, I joined IBM Canada as a management consultant, specifically in their strategy and analytics practice. So it was kind of at the intersection of technology, data, and business, which I thought was a pretty unique opportunity to bring together my skill sets. But it was really my time at IBM where I felt that I wasn't having an impact on people's lives. I didn't feel like increasing the share price of, an insurance company or bank was really motivating for me. I felt like I wanted to have more of a direct impact on people's lives, and I wanted to be able to use my skill set specifically to do so. So I thought, okay, where is that opportunity? And to me, healthcare was the obvious choice. And why specifically chronic pain is because I had a couple of people in my lives that had experienced chronic pain or dealt with pain. My mom has severe fibromyalgia. So I grew up with her telling my dad, her doctors, you don't get what I'm going through. I've had an uncle who passed away from stage 4 prostate cancer. And in the palliative stages of his life, I saw how his pain was managed in a very impersonal nature. And I thought, if I could bring my expertise to this world, if I could give patients a voice, if I could allow them to better articulate what they're going through, maybe then I can get them the care that they need from the providers. And on the flip side, if I can empower providers with better information about what a patient is going through, then they too can come up with more effective treatment plans. And that was kind of the genesis for why I decided to found Managing Life. I've been doing this for 9 years now. It is a very long journey in the world of digital health, and I'll explain that as I go through this presentation as to why it takes so long to build a digital health company. But let me take a step back and talk about chronic pain. It is an extremely prevalent condition. The general population, it affects about 1 in 5, and that ranges from kids all the way through to adults. In a recent Benefits Canada survey, 41% of the active workforce say that they live with chronic pain, and about a third of them says that it affects their ability to work. I think the most shocking statistic, however, is the one on the right-hand side. Now, this is based on data that's a bit older now, but 1 in 7 people in Ontario are prescribed an opioid medication for chronic pain every year. And with the headlines that we've all read about people dying from opioid overdose, this is an alarming statistic. Now, what's not really talked about in those headlines, where thousands are dying every year from opioid overdoses, is the fact that most people who start an opioid do so because of an unmanaged pain problem. Now, beyond that, someone with pain costs more to the healthcare system. They go to the ER more, they go to see their doctor more, they get more drugs, more medications, more surgeries. There was a study done that showed that someone with pain costs 50% more than someone without pain, with all other factors being consistent. When you try to quantify this for Canada, that represents over $30 billion of direct medical expenses associated with chronic pain. It makes it the most expensive chronic condition in healthcare, more than cancer, more than diabetes, more than heart disease. In the US, that figure is about $350 billion. It's a massive driver of costs. The second statistic there is about 30% of people on disability live with chronic pain. And so there are a lot of opportunities to better manage chronic pain and get people back to work. Now, I give you this all because whenever you start a company, it's really important, first of all, to validate that there is an actual financial motivation for solving the problem. Unfortunately, building a company, it's insufficient to just improve the lives of people. It needs to improve the lives of people and save money. And those are really, really important. And so my mission statement is to improve the lives of everyone who lives with chronic pain while lowering its cost for insurers and healthcare systems. That's baked right into our mission statement. Now, there are specific challenges when you talk about chronic pain, and there's an urgent need to help people living with chronic pain overcome these challenges. The first is self-management. When you have diabetes, you can take your blood glucose levels, you can chart it, you can graph it, and understand patterns and trends and modify your behavior. You can do things differently. Unfortunately, when it comes to chronic pain, there is a huge gap in terms of self-management tools and resources that people can do to manage their own pain. And that creates a dependency, either on their doctors to tell them what to do, or a medication like an opioid just to survive the next 30 days. People would benefit from understanding patterns and trends in their experiences so that they can modify their behavior. Now, the second part is kind of touching on what I talked about with my mom's experience, which is it's really hard to explain what you're going through when you live with chronic pain. There's no x-ray for pain. There's no blood test for pain. It's entirely dependent on what someone tells their doctor during a clinical visit. And many people don't like to complain. And so they don't really voice what they're going through until it's too late. And then they have to show up into the ER, the emergency room, and get dismissed as a drug seeker in pain. And then finally, education. Research has shown time and time again that people in pain can benefit from a better explanation of how pain works physiologically, the brain-body connection, but also to understand coping strategies that aren't therapeutic in nature. So what I mean by that is there are things you can do to manage your pain that don't depend on a medication or a surgery or physiotherapy. And a lot of that is based on something called pain psychology, which I will talk about shortly. And that pain psychology is really important because 70% of people living with chronic pain also live with anxiety and depression. Research shows that before medications, before surgery, before physio, Education and psychology should be the first thing people with chronic pain should be given, except the vast majority of people will never receive that type of support. First of all, there aren't enough pain psychologists that exist. The very few that do exist are typically localized in urban academic hospitals. And to see them here in Canada, it's a 12-month wait list if you're lucky to even be referred to one of those hospital-based pain clinics. There's also still a stigma to see someone, a psychologist, to talk about your pain. Like my mom, again, I always go back to my mom's example. I've been trying to get her to talk to a therapist for years, but she says the same thing that many people with pain say, which is, are you calling me crazy? Are you saying the pain's in my head? And so it's a real challenge to get people this type of psychological support that we know research works. Research has shown works, but overcoming that stigma. Our solution, Manage My Pain, is based on best practices in pain psychology. And that's the root of what our solution does. As I mentioned, it is already the top ranked and most downloaded pain app on the market. We have over 100,000 users and thousands of ratings and reviews that really highlight how this has become an essential tool for people to manage their pain. So what does it do? Our solution really brings together 4 different elements to people. Now, if you search for pain on the App Store, we're typically the first app that shows up. Sometimes there's a game called Mr. Pain that we can't really beat in the search engine, but it is what it is. But the first thing that we do is symptom tracking. And it's built on something called acceptance and commitment therapy, or ACT. ACT is a subset of CBT, cognitive behavioral therapy, which is a form of psychology. And what we do is we ask people about their day and how it made them feel and what they accomplished in their day. Very much a positive reflection of your achievement and accomplishment. Once people do that, then we ask them about their pain, where it hurts, what medications they took, etc. The entire experience is designed to take place in less than 60 seconds. But it's not just data entry. As soon as people enter information in, we play back that information through charts and graphs to highlight patterns and trends. So, is my migraine getting worse when it's cloudy outside? Is that cannabis helping me sleep? Think of it as the Fitbit for pain. Now, the third component is the education. This is where we teach people about how pain works. We try to emulate what a pain psychologist would talk to their patient about, but instead of 12 one-hour sessions, we do it in 2 to 3 minute little micro learnings, and we don't call it pain psychology. So as people are tracking their pain, we teach them about coping strategies that they wouldn't otherwise be exposed to. And so we're trying to provide psychology in a way that people don't even realize it. But the real reason people use our solution is the last component, which is the reports. As they use our app, they can convert all that information into a one-page report that they can then take to their doctor, to their physiotherapist, to their surgeon, to their anesthesiologist, and it becomes their voice. My pain is real. It looks like this. You need to treat me. In fact, when I was first building the company, I really spent a lot of time trying to understand the motivations for people in pain. What would actually drive them to use our solution? And time again, the number one response was, I want my doctor to believe me. So a lot of effort in our company's evolution has been focused on what that report generates or looks like, and is it clinically relevant? And I'll talk about that a little bit. So how does it work? At 8 p.m. every day, there's a little reminder that goes off on your phone. And what we don't do is ask you about your pain. Instead, using ACT, people are asked to reflect on what they did in their day that was meaningful and important to them. Now, this screen and this question was actually co-developed by the University Health Network, which is Canada's largest academic hospital, over an 18-month-long project, where there was a multidisciplinary group in their pain clinic. It had anesthesiologists, psychologists, physiotherapists, nurse practitioners. I think there was a yoga practitioner in there. And I challenged the group to say, if you all could only ask one question of your patients that measured function, what would that question be? And function means how much you're able to do in your life that's important, that's meaningful, that's productive. It's really the only metric that matters when you talk about healthcare, is how functional are you? And so we came up with this concept called the daily reflection. And the question is, what did you do that mattered to you today? And 0 means nothing and 10 is everything I wanted. Now, if you're recovering after surgery, maybe everything you wanted to do is get out of bed and go to the bathroom by yourself. But if you have fibromyalgia and you're still at work, maybe it's putting in 8 hours a day and then coming home and cooking a meal for your friends and family. What doesn't matter is any individual answer. What matters is how you answer this question over time. It doesn't matter that I get compared to you or you get compared to another person. What matters is you compared to you over several weeks or months. Now, the second question is, what did you do? And it comes pre-populated with both a set of physical activities as well as psychosocial activities. And this is where people can add custom values to the solution to really check what's important to them. Now, why is this concept important? Is because when you talk to someone with pain, many times it's hard to forget. It's hard to remember that they're still able to do things in their life that are important and meaningful despite their pain. And they focus many times on the negative as opposed to what they can do. And so this is a slight shift in their approach to say that you are still able to do some things. Let's track that. Now, once people track what they can do, then we ask them about their pain. How bad is it in terms of severity? Where does it hurt on your body? What else besides pain are you feeling? Stress, anxiety, constipation, numbness, whatever. What words describe your pain? If you use words like aching and dull, that implies musculoskeletal pain. If you use words like tingling or numbness or electric shocks, that implies neuropathic pain. Really, really important to differentiate between the two. And there's no way to detect that unless people use certain words during a clinical visit. What are your triggers? What medications did you take? How did it make you feel? So the idea here is for people to get in and out in less than 60 seconds. And as they use it, as I mentioned, we have something called a pain guide that teaches people about how pain works across 4 different categories, where learning about pain and how it works, coping strategies that a pain psychologist would talk to you about, treatments, and then sharing user stories from others. Now, every article in here was co-developed by the pain psychology team at UHN, and every article was validated by several psychologists to make sure that it was clinically accurate. And so the idea here is really shorten the amount of information that we're giving to people and allow them to self-guide through it. The reason why pain psychology isn't offered to everyone is because not everyone wants to go through 12 one-hour sessions or can afford it or has access to it. And so we wanted to create something that was highly scalable and touched on these elements in a purely digital fashion. And as I mentioned, charts and graphs highlight patterns and trends. So you can understand what you can do about your own situation independent of the doctor. Now, what do all of these things give you? It gives you a sense of control. One of the biggest challenges for people with chronic pain is they've lost that sense of control over their condition. And we're trying to return that sense of control to some degree. We're not dismissing their pain. We're not saying it's not real. We're just giving them a tool that allows them to do something about that while they're seeking out care. But I think the biggest opportunity are the reports. When we asked our users what they wanted, as I mentioned, getting my doctor to believe me was the number one thing that they said. And the 2 graphs that you see there don't exist in the world of pain management outside of our solution. On the top left is your pain score over time with a trend line. And on the right is your function, what you're doing in your life over time with the trend line. Now, why this is important is because typically when you have chronic pain, you talk to your doctor once every 3 months, and they'll ask you, so tell me how you feel since the last time I saw you 3 months ago. And your answer is going to be dependent on how you feel that day. You'll probably say, well, over the past 3 months, nothing worked. It was terrible pain. But using a report like this, even though if you look at the rightmost data point, which is January 31st, the pain level is a little bit higher. But if the doctor asked that question, the patient would have probably said, over the past month, my pain hasn't changed. I need that stronger opioid, or I need that surgical visit, or whatever it is. It allows the doctor to say, well, it doesn't feel like it today, but whatever treatment we started a month ago is having a positive impact. Your pain levels are coming down. There's going to be some bad days, but the pain levels are coming down, and you're actually doing more in your life that's important to you. But I noticed that you have new chest pain and a little bit of dizziness. So let's talk about that. The patient feels validated, and the clinician gets to the information that he or she needs to make a treatment decision using data as opposed to subjective recall of the patient. Now, there's 3 ways that our app is used. Entirely self-management. You can go to the App Store, use it independently of a doctor, and just use it to figure out patterns and trends and to learn about your pain. The second is you can generate the reports and take it to your doctor. Now, someone with pain is seeing their family doctor. They're seeing a chiropractor. They're seeing a physiotherapist. They're seeing a surgeon. None of those people are ever talking to each other. And so it's up to the patient to become their own advocate and champion. And that's where these reports are very, very powerful. And then finally, when we do partner with a provider or insurance company, We also have something called a remote monitoring portal. So with consent, all the information collected in our app can be shared via a web-based remote monitoring portal, where this information can be seen at the individual level or at the aggregate across an entire population. And that remote monitoring portal is where we add another layer of functionality. We can also put in existing patient-reported outcome measures, or PROMs, which are the current way that many hospitals or clinics use to evaluate progress. So we can have formal validated questionnaires that are issued through our system, where we automatically remind people to complete them and we automatically score them. We have thousands of different questionnaires that we support. And now, in between clinical visits, a clinic can actually see progress. Now, a real use case of how this is being used at the Toronto General Hospital, what they found is that about 15% of people that went through a major surgery, like a transplant, went on to develop something called chronic post-surgical pain, and were still dependent on opioids 6 months after surgery. That's a very high number. And so they wanted to be able to understand how people were progressing with their pain after surgery in between visits while they're still recovering at home. And that's how they use our platform. So if they see that a patient is moving in the wrong trajectory, they intervene, they call them, they bring them into the clinic, and they use our tool to actually assess treatment options. But I think one of the most interesting parts of our solution, because I'm a data guy, we've built out 33 clinically validated alerts that look for patterns and trends. And we can actually flag at-risk patients weeks, sometimes months sooner than ever possible before. We can detect people that have mental health issues, detect people that have something called neuropathic pain, detect if they have side effects consistent with excess opioid use, all weeks, possibly months sooner than a doctor could ever do that, because people are interacting with our app daily. And as I'll talk about shortly, we're moving more towards predictive analytics. So imagine being able to put in our portal the likelihood that someone before surgery has a higher likelihood of developing post-surgical pain, or if someone is at risk of going on disability because they're trending in the wrong way. These are game-changing predictions that can only be done with large data sets. And that's something that we are collecting. Now, data protection is a really important concept. We are very much a data company. So we had to go through external validation to make sure that we could actually protect people's data. We are SOC 2 Type 2 certified, which means that we are we have an external auditor that's looked at our administrative and technical safeguards to make sure that we actually protect patient data that's put into our app. And we're compliant with privacy legislation across Canada, US, and the EU as well. So as we built out this product, we encountered a number of challenges that I'll share with you today. The first challenge for any digital health company should be, will people use it? Engagement is by far the most important metric, I believe, for a digital health company. Unfortunately, many companies and solutions don't focus on that first. They focus on what's the evidence or research that went into developing it, or does it work clinically? If your solution works clinically, but only 1 out of every 1,000 people actually use it, it's not going to be effective. When we partnered with the University Health Network back in 2015 or 16, they had already received a $1 million grant to build their own pain app. They built it out. They had it on the market for about 12 months, and they only had 50 downloads. And so when I approached them, I had 20,000 users at the time. And so it was a very obvious choice that the clinicians could make to say, it's kind of pointless if no one's going to use this solution. You've nailed the engagement piece. Let's see if we can leverage that as part of our clinical workflow. So that is really our secret sauce, is we have a unique ability to engage people living with chronic pain. And that's why I keep mentioning the reason people use our solution. So when I went down this path, as I mentioned, I didn't talk to doctors or researchers or insurance companies for 4 years. I only spoke to people with chronic pain. And I asked them, what motivates you? What do you need? And the 3 responses were, as I mentioned, I need my doctor to believe me. Number 2 is I need to figure out how to manage my own condition independent of a doctor. I need something to help me understand what's going on in my body. And the 3rd is I need evidence to support an insurance claim. And so that really guided the evolution of our product. And we measure engagement using something called retention rates. So it's a very common metric in the mobile world, where it's from the time of install to 1 day later, are they still using it? 7 days later, are they still using it? And 30 days later, are they still using it? The top performing health apps have a 15% 30-day retention rate. And this is based on a survey of the 1,000 top performing health apps. Our 30-day retention rate is 30% when you find it on the App Store. But when it's referred to a client at a disability carrier, that number jumps to 52%. And then finally, when it's actually referred to by a clinician, that number jumps to over 60%. And that's published in a peer-reviewed journal. We now have over 85,000 activated users who have recorded 3.5 million records in our data set. So this was really, really an emphasis area for us. Anytime we develop a new feature, we always run A/B tests. So what that means is half the population gets the change, half the population doesn't. And we define metrics like number of clicks, flow throughs, retention rates, and we evaluate whether or not that change had an impact on engagement. And that's a really important consideration as you build out or consider digital health, is getting people to use it. The second challenge that we had to go through was who owns the data? Now, this is a really big challenge because when we first launched our app in 2012, we were the very first paying app on Android. And when we first engaged UHN back in 2015 is when we first started engaging with them. There were no other digital health solutions out there. They weren't using any. It was still very early in the cycle. Fast forward to today, obviously it's a lot more prevalent. It's a lot more accepted, and we've kind of figured this out. But for us, owning the data was a really interesting question. And so from day one, we've always had the same principles. Who owns the data? The patient owns their own data. And that was a foreign concept to many hospitals at the time, where they had traditionally been the gatekeepers of this information. They retained all the information, they kept it on their own systems, they had a liability for it, which is not the situation with our solution. Ours is a patient-owned data set. They own their own data. We are the custodian of the data, not the hospital, not the insurance company. But what they can do is they can license it from us and use it only if the user provides us with permission to share it with them. And that changes the flow of data that was traditionally in play. Normally, when an insurance company or hospital partnered with an external organization, it was the other way around. They would own the data and we would have to get permission to see it and process it, and they would control all aspects of its use. So this was a really difficult question to address for us. It took us 9 months to navigate that process with UHN before we finally got them to agree that the data belongs to the patient and UHN doesn't own the data. Fast forward today, some insurance companies still have this challenge. I'm going through a contract negotiation right now where this is the last sticking point in the contract. The insurance company wants to own the data. But some insurance companies have completely changed their perspective where they say, we don't want the data. We don't want the liability. We don't want ownership over it. We're happy for you to kind of be the custodian. So I think it's still an evolving area, but I think that was important for us is privacy by design. From day one, the patient needed to own their own data, and we kind of handled it that way. Now, the last question, so how does it work? The way it works is when we work with a hospital or an insurance company, they invite people to participate in our program. They register, they give them a code, or they just give them a website. Then we set up a dedicated landing page for them, and they're shown a consent screen that says, do you, patient, provide us, Managing Life, with permission to share your identifiable information for these purposes with this organization? And only when they say yes, do we allow them to use it. And then they use it at home. The clinic can assign questionnaires through our system, through the monitoring portal. They can use it during clinical appointments. And then finally, the goal is an empowered patient. So brings me to digital health challenge number 3. And this is, unfortunately, the hardest part for a digital health company in my mind, is proving that your solution works. And works has a different definition depending on who you're talking to. If you're talking to a patient, it means getting rid of my pain. If you're talking to a clinic, it typically means improving clinical outcomes. But in Canada, the way our healthcare system is defined, pain clinics don't get paid more if they make your pain go away. They get paid every time you see them. It's a fee-for-service model. So they are not financially incentivized to improve your pain. So does it work? Or a clinic really means, does it create operational efficiencies? Does it allow them to operate their pain clinics at a lower cost? And then finally, for insurance companies, does it work? Means lower costs as well. So for disability carriers, that means a faster return to work. For health insurance companies, that means fewer claims, less time in hospital, less procedures, less medications. And so it's a really big challenge to answer this question. But I think we spent a lot of time doing our best to generate evidence that our solution works across two main domains. The first is clinical outcomes. So thankfully, with federal funding, with provincial funding, we were able to run a 3-year multi-site validation study across 2 different clinics. I think I have the slides coming up. I just want to confirm that. No, okay. It involved Toronto General, Toronto Western, which are both urban academic hospital clinics. And then we also included Iroquois Falls. Iroquois Falls is a tiny town of 7,500 people, 11 hours north of Toronto. They're very rural. They have a large catchment area where they service a large number of First Nation reserves as well. Very different patient demographic. And we had an external research team at Unity Health evaluate the project. So patients at these clinics were given our app, and patients that used it were compared to patients at the same clinics that didn't use the app. And the researchers found clinically and statistically significant improvements in those that use the app. But the improvements were not in what you would think of when you think of pain, not in terms of pain severity or pain interference or things like that, but more from a mental health perspective. People that use the app saw significant reductions in anxiety and pain catastrophizing. Now, what's pain catastrophizing? It's how much people dwell on their pain, how much they are focused on their pain. And both anxiety and pain catastrophizing are correlated with worse outcomes. So you need to address anxiety and pain catastrophizing before that surgery is effective, before that medication works, before that physiotherapy is accepted. And so that is what our solution is able to do. It's a complement to care. The second thing we did is we worked with RBC Insurance. If you're not familiar with RBC, it's Canada's largest company. And in their insurance practice, they offer an insurance product to employers called disability, both short-term and long-term disability. And what that means is when someone is medically unfit to work, they file a disability claim where a percentage of their salary, typically 40 to 60% of their salary, is paid for out of the insurance company's policy. And it's for life or until you are well enough to return to work. Now, you can imagine if a 25-year-old goes on disability, they are responsible for paying their salary until they are 65 years of age. So that creates a significant financial incentive to help people. As I mentioned in one of the earlier slides, 30% of all disability claims are due to chronic pain. And each month is about $3,000 to $5,000 in benefits that they have to pay. So what we did is at RBC offered our solution to people on both short-term and long-term disability. Now, the typical disability claim duration is about 3 to 5 years. So if you're going to make any suggestion that your solution gets people off claim and back to work faster, it means you need to run a project that's 3 to 5 years, which is what we did. It was a 42-month long project, 42 months. And RBC was able to evaluate the data of people that used our app compared to a matched cohort of people that didn't use the app. And RBC's data showed a 7.5-month shorter disability claim duration in those that used our app. After about 6 months of negotiating with their legal team, we got permission to publish this information in a case study, and that's on our website as well. So now we have 2 really big pieces of evidence that our solution works. So in a 3-step process, we proved that people with pain will actually use our solution. We navigated the data and the consent question. And finally, we have proof that our solution works. Now we're at the point where we can seek out people to pay for our solution. So what's our business model? How do we make money? That is digital health challenge number 4. There are 4 stakeholders when you talk about healthcare. There are the patients themselves. So if you're asking the patients to pay for it, that's a direct consumer model. We do have a direct consumer option. You can go to the App Store and subscribe for $6.50 a month or something like that to our app. It's not our primary business model. Providers who deliver care, as I mentioned, aren't financially incentivized to improve clinical outcomes. They don't also have the budget to pay for a digital health solution that improves care. And so that's a really difficult sell for us. On the left-hand side, there are pharmaceutical companies or manufacturers that could probably pay for our solution, but they're also the ones that caused the opioid crisis to begin with. And so I've shied away from partnering with most pharmaceutical companies. But at the end of the day, what they're trying to push to make money for themselves is adherence and refills, getting people to use their product more. That's how they make money. And so our solution is kind of counter to their goals, which is trying to help people get improved outcomes so that they don't need those products. And then finally, that brings us to the last stakeholder group, which are the payers, people that pay for healthcare or other insurance products. And that's really our business model. It's to license our solution to 2 different groups: employers, health plans, and at-risk providers. These are the ones that pay for healthcare. So in Ontario, that would be OHIP. In Alberta, it would be Alberta Health. In the US, it would be a private insurance company, Kaiser Permanente, Blue Cross, whoever your plan is, Humana, Cigna, Centene. And their motivation is to reduce medical spend. So what does that mean? A surgery in the US, $50,000, $100,000 in costs. So if you can help someone better manage their pain a year before that to avoid a surgery, that has a huge financial return for that organization. That's a good opportunity area for a solution like ours. And on the right-hand side, disability and workers' comp insurance companies, where they're motivated to reduce claim durations and get people back to work faster. And that has been our short-term focus. And we've been partnering with a lot of organizations to really integrate our solution into the claims experience for people that are disabled. So the last thing I want to share is our machine learning papers. So as I mentioned, we've now got the world's largest data set of patient-reported pain information from our user base. And that gives us a unique opportunity to aggregate and de-identify the information and publish unique insights on it. So we've partnered with a number of academic organizations to apply machine learning concepts to our data set. And it started in 2017, where we applied unsupervised machine learning techniques to our data set to really answer the question, who uses Manage My Pain? And profile them in terms of their gender, their age, their medical history. And we found some really interesting results there. Now, the second paper in the middle looked at 1 month of app data to predict pain volatility outcomes 6 months in the future. At the time of its publication, it was the world's first prediction paper in chronic pain. It was based on 134 different factors that predicted whether or not someone would have highly volatile pain in the future or not. And knowing that someone will or will not have highly volatile pain 6 months in the future isn't really useful for a clinician unless they also know the levers that can influence that trajectory. And that's what the third paper was. It was bringing down those 134 to identify the top 8 contributing factors. And that made it human readable, if you will. It allowed clinicians to understand what went into that prediction model so that, in theory, they could better treat it earlier on in the cycle. Coming up in January and, through the support of the MedTech Accelerator. So we were able to bring on an intern who will be looking at the next evolution of our papers, which is predicting more clinically relevant events like anxiety, pain catastrophizing, pain interference. These are going to be game-changing prediction models that will really influence how a patient is treated now to improve their outcomes in the future. So I bring that up just because many of you may be involved in machine learning, and we work with a very unique and proprietary data set that's very large, and it's a useful application of the machine learning models that we are going to be actually implementing and incorporating into the services that or the products that are currently used by clinics. We work with 13 different clinics across Alberta Health Services. We work with the University Health Network at 2 clinics, and we've got about 3 or 4 different hospitals that we'll be launching in the coming months. So that is what I wanted to share with you today. That brings me to 1:45. So I wanted to leave enough time for some questions if there were any. I'm happy to kind of expand on any of the things that I talked about. If you had some open-ended questions or questions about things I hadn't talked about, happy to discuss and explore them as well.